Hi, everyone. I thought I'd try something new today, and in preparation for our session on Monday, I'm going to try a screencast to share a little bit about maternity care with you. We're going to be talking about pre-pregnancy counseling and first trimester pregnancy expectations and a little bit about care. So here is pre-pregnancy counseling. So one of the things that we actually don't do enough in family medicine is think about pregnancy when we're just seeing women in routine care, right? We got to keep in mind that a lot of times people may not be planning pregnancy, or they may not think about telling us about it because they may be planning to go see an OB provider for their care. So we should be asking women about their risks, their family history, any STIs that they might have or have been exposed to, any comorbid conditions, and we might have to think about labs, especially if a patient tells us that they know they're planning to get pregnant. It's super important to think about prenatal vitamins, especially having at least zero point 0.4 and up to 1 milligram of folate that starts preconception. All right. And then we have to think a little bit about aspirin for preeclampsia prophylaxis. So this is a little bit about the ACOG guideline because this is something that's fairly new and you may not have heard about this in medical school. 81 milligrams per day is what's recommended for preeclampsia prevention for high-risk women. We'll talk about what that means in a second. It starts after 12 weeks, so often that's after they've established care with an OBGYN. But we definitely want to start by 16 weeks. And so if we're seeing a patient who may have delayed her presentation for care or have been uncertain about her plans for pregnancy, we need to know a little bit about this so that we're ready to go. And then they continue the aspirin 81 milligrams a day, daily until delivery. And as a result of that, there is a 10 to 25% reduction in preeclampsia incidence. Now, that's a meta-analysis of small trials, and we have to acknowledge that small trials may overestimate the benefit. Who's at high risk? Well, here we go. So certainly everybody in this high risk category, they are recommended for low dose aspirin if they have any of these things. So that's history of preeclampsia, certainly multifetal gestation, all right, so twins, chronic hypertension, diabetes, type 1 or 2, renal disease, and autoimmune disease as well. So any of the conditions that are listed there, but also other autoimmune diseases. And then we have this sort of moderate category in which we could consider low-dose aspirin. This really covers a huge number of our patients. So they should have 2 of these to be considered. But think about it, a nulliparous woman, an obese woman, someone who has a family history, a first-degree relative of preeclampsia, socio-demographic factors, so African-American race, low socioeconomic status. We certainly see a lot of those at our offices, advanced maternal age, and then you can see some of the other things there. So any of these people can be considered for high risk for preeclampsia. As we go back to preconception counseling, now that we've decided whether this person needs aspirin or not, we also just want to make this a part of our contraceptive. We want to make sure that we're checking in about emotional and financial readiness. Those are questions that we often don't ask. And we want to think about if there are any habit changes that need to happen, any suggestions we can make about weight management, tobacco, alcohol before the pregnancy. And again, we want to make this a part of our contraceptive counseling thought process. So if somebody's coming in for contraception, or if they're thinking about having an IUD removed or a Nexplanon removed, any of those sorts of things, think about pre-pregnancy counseling, all right? So in terms of identifying pregnancy, that's sort of the next step here. So in what patients should we think about pregnancy? The answer here is E for everyone, okay? Any a woman of childbearing age that has a new symptom, we should really be thinking about it. Here's some pictures that may help us to remember some of the things. Any new abdominal pain, an absence of a period, breast tenderness, headache, obviously the nausea, and we talk about morning sickness. We know it doesn't have to be morning sickness, increasing fatigue, some of those sorts of things. So we need to think about this, and we need to be considering it anytime that we're seeing a patient with a new symptom. And especially in terms of abdominal pain, we need to consider that ectopic pregnancy is a possibility as well. Now, obviously, this is something that we talk about quite a bit, so I hope you've heard this before. But this statement, congratulations, you're pregnant, yay, is not the best way for us to react to a pregnancy test, right? First, we have to assess whether pregnancy is intended, and then whether it's desired. And patients may not even know how they feel about that. But it's super important as we're going in to tell a patient that a urine pregnancy test in the office is positive, that we check in and just ask the patient, how would you feel if you were pregnant? Were you planning to get pregnant? Some of those questions first, so that we can be prepared for the answer. And if they say, yes, absolutely, this is intended, then great, congratulations, you're pregnant, is a wonderful statement. But it may not be in all cases. It's also important that we know the resources available for termination and consider some of the ethics with that decision, including our own ethics and how that may bias our conversations for a woman. So we need to know on either side of that issue, how we're going to approach the conversation. Of course, the family life cycle is something that we keep coming back to. If we were in the learning lab room, I'd be pointing to it on the wall of the learning lab. So we need to remember that this whole idea of having a baby is a part of this adding a generation, right? And so there are a lot of different ways in which a generation can be added. We're going to be talking mostly about heterosexual parenting, but many of the same things can be said of same-sex parenting, of single parenting, because patients may use infertility technologies, adoption, and again, childbirth. These are all pieces of it. It's also important to remember that adding a generation can happen at various stages in life. So it can happen before coupling, right? A single adult family, right? It can happen in adolescence. It can happen as a result of rape. So there are a lot of different ways in which the family life cycle can be impacted. And keeping in mind, it's not just the patient who's there in front of you. It's the whole family unit that is impacted by this. So it's really important as we're considering a new pregnancy to think about the family life cycle. Evaluate what is the relationship between the future parents like? A single parent? Is it a couple? And if so, are they in a place in that life cycle where they're ready to be adding a generation? Or was this unexpected? And so, think a little bit about, which are the most important pieces of that to consider as you're dealing with each individual patient. You may find that there's more excitement in one parent than another. And that's a very common thing. I was actually watching Big Bang Theory just a few days ago, and there's actually a whole kind of sequence that's about new parents not being sure how they feel about a pregnancy. And then we also have to keep in mind, what does the rest of the family think? What about the supports that are there? Are there healthy habits that are in place, or more importantly, unhealthy habits that we may need to address? And so it's also important in terms of the family life cycle to invite appropriate supports to future appointments. Now, that doesn't need to be for everyone. Some people might prefer to be on their own, but it is something that we can consider. All right, so now that we know that somebody is pregnant, we're going to move into the first trimester. And so one piece of this is to remember, throughout all of pregnancy, it's really important that we keep swinging. Okay, a lot of times it's very easy, just like every place else, to stay focused on the physiologic limb, all right, and think about the physiologic effects of pregnancy. But what are the emotional, social, spiritual, and conceptual aspects of the pregnancy? And what are the effects of that on not only the patient, but the whole family, right? Domestic violence, we'll talk about in a second. Super important to include a domestic violence screen in a pregnant woman. Thinking about the healthy habits. We've already talked about some of these things. I won't go into them further. And financial stability, again, something to ask about when you're dealing with a first trimester pregnancy. Very important from a medical perspective to make sure we have accurate dating. All right. So most of the times patients get an ultrasound. Okay. But if you have an accurate LMP, it's not necessarily needed to do a dating ultrasound specifically. In our system, it almost always happens. Immunizations. Are there any immunizations that they have? Keeping in mind that live virus vaccines aren't appropriate for pregnancy. Okay, so but if there are other vaccines that are overdue, may be considered. And then here are the labs. So important to remember these things. Not that you necessarily need to be the one ordering them, but keep in mind that things like blood type, Rh status, CBC, especially the STI screenings, right? And immunization status. A lot of these things would be great to actually include as a part of our preconception counseling, right? Because wouldn't it be better to know if a patient has HIV before she gets pregnant? Uh-huh. Absolutely it would. Or if she's got syphilis. Absolutely. We want to know that. Gonorrhea, chlamydia. Not a bad idea. If someone knows that they're going to try getting pregnant, that we start that, potentially even a vaccination series, right? So there's very little on this lab. Maybe not. We may not need to know their blood type and Rh status. We may not need a hemoglobin electrophoresis, but maybe, if somebody's at risk for having hemoglobinopathy, maybe they would choose not to get pregnant or make a different choice, right? All right, some typical symptoms in the first trimester. There you go. You can see we already went through a lot of these things: fatigue, swollen breasts, upset stomach, morning sickness, vomiting. Doesn't have to be vomiting. It can just be nausea. It can just be a loss of appetite. Vaginal discharge can change. Cravings, distaste for certain foods, mood swings, constipation, urinary frequency. Headaches, heartburn, weight gain or loss, all of those things can be a piece of it. So just keep in mind, again, any new symptom in a woman of childbearing age, just ask yourself, could this be related to pregnancy? And if you're not sure, do a test, not too hard. All right, domestic violence, we know that pregnancy affects domestic violence rates, okay? Here it is, 15 to 25% of pregnant women are battered. It's probably underreported, so that's probably low. 40% of assaults on women by their male partners begin during the first pregnancy. So especially in first pregnancy, super important to ask about safety in the home. And again, I'm not going to belabor this in a whole lot because we've talked about this before, but it's great to know how to screen. So have you ever been in a relationship where you don't feel safe? Do you feel safe in your current relationship? Those are indirect questions. And then specifically direct questions. Consider getting comfortable asking, have you been hit, kicked, punched by somebody in the past year? Avoiding emotionally charged words, and don't pressure, okay? But it's not emotionally charged to say, have you been hit, kicked, punched, or otherwise hurt by someone in the last year? No, there doesn't need to be emotion in that. And you can also use some framing questions. Because this is so common, I regularly ask my pregnant patients if they have been hit, punched, etc. All of these are other potential ways that you can go into it. And again, this is something we've talked about in the past. Super, super important in pregnancy. And then some interventions. So, if there is an acknowledgement that that's been there, do you feel safe? Would you like to remain in your current relationship? What do you usually do when things get out of hand? It couldn't be as simple as having a number to call, and you see the number there, the Turning Point hotline. That's just one of many options in terms of what people can call. It may be very complicated and detailed in terms of how you have to do a safety plan. And so I definitely encourage you to think that through. So that will be everything for this pre-work talk. And I look forward to seeing those of you who are able to be there on Monday so that we can get into more. Thanks.